Welcome to Deep Dive Ortho. Today we're tackling something I think is one of the toughest challenges in upper limb surgery. We're talking about managing the arthritic elbow, but specifically in the young, active patient. And this isn't just about getting the diagnosis right. It's about navigating that really difficult conversation where a patient's high expectations meet the, let's be honest, very real limits of our current technology. Guiding us through this is a leading expert in complex joint preservation and revision arthroplasty. A huge welcome to the show.
Thank you. It's great to be here. And you've hit the nail on the head. It's all about that tension between durability and demand. When we're looking at this younger, high-demand group, we're almost always dealing with either primary degenerative osteoarthritis, DOA, or post-traumatic arthritis, PTA. I mean, yes, you see inflammatory conditions like core-OA, but modern therapeutics have really changed the game there. The real mechanical puzzle, the thing that keeps us up at night, is that under 50-year-old with PTA or DOA who wants to get back to a physically demanding life.
Okay, so let's get straight into that. Our audience knows the basics of elbow pathology, so let's dive deeper. For our peers listening, what are the specific clinical signs, the radiographic features that really separate that mechanical primary OA from the structurally failed post-traumatic joint? And how does that difference immediately start to shape our treatment plan?
Right, that distinction is absolutely vital. You have to triage from the moment you see the patient because you're dealing with two very different underlying problems. Primary OA, or DOA, has a very classic profile. It's overwhelmingly a disease of men. We see it in the dominant arm in, 80 to 90% of cases. And symptoms usually start cropping up in their 40s or 50s, even though the damage started much, much earlier. And critically, you see this incredibly strong link in about 60% of them to repetitive heavy use. Manual laborers, people using pneumatic tools, or sports like weightlifting.
That history of repetitive axial load, it suggests a very predictable kind of wear pattern.
It does, exactly. And our current thinking is that the whole process kicks off at the radiocapitellar joint. It's a joint we often underestimate, but it supports around 55% of the axial load when the forearm's in neutral.
Right.
So the wear starts there, and only later does it progress to the main ulnohumeral joint. Radiographically, what you see is extensive osteophyte formation around the edges, a really profound capsular contracture, lots of loose bodies, but the central cartilage can actually look relatively okay until very late in the disease. Post-traumatic arthritis, on the other hand, well, it's a story of architectural failure. It's a direct consequence of a previous injury, a malunion, a non-union, some kind of residual incongruity in the joint. And the clinical picture is it's often dominated by stiffness, really intractable stiffness from the original injury, the scarring, the contracture. The x-rays tell the story of that old injury, and you know you're dealing with a hostile environment from the start.
So if the mechanics are so different, the pain itself must be our ultimate guide. How does the character of that pain, where it is when it happens, point us towards either preserving the joint or, well, having to accept that it needs resurfacing or replacing?
This is probably the single most important clinical tool we have, the symptom compass, as you call it. It really boils down to two distinct presentations. First, you have what we call terminal pain. This is pain only at the very extremes of motion. Full flexion, or when you force it into full extension.
Classic impingement sign.
Precisely. The pain isn't coming from the articular surface itself. It's mechanical. It's bone hitting bone. It's the coronoid process jamming into its fossa inflection, or the olecranon tip hitting the back and extension. This is the patient who does beautifully with the joint-preserving cleanout and osteocapsular debridement. You take away the impingement, the pain goes, and they get some motion back.
Okay, so that's the good news story. What's the red flag?
The red flag is mid-arc pain, or pain at rest, or critically, night pain. That tells you it's not a simple mechanical block. It tells you the entire bearing surface has failed. This is what we call the bad bearing joint. And this symptom correlates almost perfectly with severe cartilage loss and significant joint space narrowing on the x-ray, particularly of the ulnohumeral joint. When you have mid-arc pain, a simple debridement is doomed to fail. You are now firmly in the territory of arthroplasty.
That's such a critical distinction. Terminal pain is a mechanical problem. Mid-arc pain is a cartilage problem. So when we're planning to tackle that mechanical issue, beyond the plain films, what other imaging really helps guide the surgery itself, especially when you're mapping out those complex osteophytes for a minimally invasive approach?
Plain films, your AP, lateral, and obliques, are your workhorse. They confirm the diagnosis, you can grade the disease. But if you are planning a joint-preserving procedure, especially an arthroscopic one, then a CT scan becomes absolutely indispensable. A CT is just far superior for spotting and, crucially, for mapping out the osteophytes and any loose bodies. You get much better agreement between surgeons on the plan. In fact, a 3D reconstruction from that CT scan it's literally your roadmap for the operation. It tells you exactly where the coronoid osteophyte is, where the olecranon osteophyte is, and that dictates your portal placement for arthroscopy, or where you need to fenestrate the humerus in an open procedure to get access.
So it's not just diagnostic, it's a genuine surgical planning tool.
100%. And while we are on diagnosis, there's one more step that's not imaging, but it's probably the most important of all.
The ulnar nerve.
The ulnar nerve. You cannot overstate this. Up to half of these patients, particularly those with a bad flexion contracture, will have some element of ulnar nerve compression. It can be trapped by osteophytes, stretched by deformity, and if you miss it preoperatively, you are setting yourself up for a disastrous postoperative ulnar neuritis when you improve their range of motion and suddenly put that nerve on stretch. So you have to document it clinically, and if there's any motor weakness, electrophysiologically with nerve conduction studies. Ignoring the nerve is not an option.
Right, let's pivot to the conservative end of things. Before we even think about surgery, what's the actual evidence for non-operative management? And maybe more importantly for our colleagues, are there any specific injections we should be actively warning patients away from?
You have to pursue conservative management vigorously in this group. You really do. Because any surgery, as we know, is a bridge burn. The mainstays are what you'd expect. Activity modification, that's the absolute non-negotiable part, avoiding that repetitive heavy lifting. Then simple analgesia, so your NSAIDs and paracetamol, and a good physiotherapy program to maintain the motion they have. For flare-ups, a steroid injection into the joint is a perfectly reasonable tool. It can give good temporary relief, breaks the pain cycle, and lets them get more out of their physio.
Okay, but what about the things to avoid? We see a lot of extrapolation from other joints, especially the knee, when it comes to things like viscosupplementation.
And that's a real problem in the elbow, especially for post-traumatic arthritis. The big caveat is hyaluronic acid. The evidence we have, which is mostly focused on post-traumatic OA of the elbow, it suggests it's not effective, plain and simple. Patients might say they feel a bit better for a few weeks, maybe up to 3 months, but by 6 months, there are no discernible benefits at all, no improvement in function, no improvement in pain scores. It is not an evidence-based intervention for this condition.
And it's not FDA approved for this indication either, is it?
It is not. And given the lack of evidence, the cost, and the very short-lived relief, we really should be counseling our patients against it. We need to stick to what's been proven to work.
So let's say conservative measures have failed, and we've got the ideal patient terminal pain-only cartilage looks pretty good. Let's talk about the joint-preserving options, the outer bridge Kashwagi, or OK procedure, and osteocapsular arthroplasty, OCA. What are the real goals there, and what can we tell patients about long-term success?
The whole rationale is targeted mechanical decompression. The indication is pure terminal range pain with a preserved ulnohumeral joint space, and the goals are threefold. 1, get rid of all the loose bodies. 2, debride all the impinging osteophytes, coronoid, olecranon, everything in the gutters. And 3, and this is key, a subtotal capsulectomy. You have to release the tight anterior and posterior capsule to deal with the contracture. Many of the open techniques also involve what we call fenestrating the humerus.
Creating a window.
Exactly. You create a window through the thin bone in the olecranon or coronoid fossa. You're essentially deepening the fossa, giving the tip of the ulna more room to move before it bangs into bone, is how you gain those last few crucial degrees of motion.
And how durable is that? What can we promise an active person?
For the right patient, it's actually very encouraging. The long-term studies, looking out to around 7 years or so, report good to excellent results in about 75 to 80% of patients. On average, you're looking at a gain of around 20 degrees in their functional arc of motion. It gives them substantial relief, and you haven't burned any major bridges for the future.
Now, there's always the debate, open versus arthroscopic. Where has the consensus landed on that?
It's a good question. Both are effective, there's no doubt. But for primary DOA, the consensus has definitely shifted towards arthroscopy. The visualization inside the joint is just better, so you're more confident you've removed every single loose body. And, the trauma to the soft tissues is less, the scars are smaller, and the early recovery can be quicker.
But isn't there some data suggesting the open approaches might get you a slightly better gain in flexion?
There is, and it's a subtle but important point. Some reviews have shown a slightly greater mean gain in flexion with open surgery, maybe 19 degrees versus 10, but that could just be selection bias. Surgeons are probably tackling the most severe rigid contractures with an open approach anyway, and the risks are higher, more dissection, more risk of hematoma. So for most cases, the expert community has really embraced the arthroscopic approach, assuming, of course, the surgeon has complete mastery of the anatomy and the portals.
Which brings us right back to the ulnar nerve.
It always comes back to the nerve. The risk of a postoperative ulnar neuropathy is real. It's reported as high as 11% after an arthroscopic release. And the risk is highest in patients who start with a bad flexion contracture, less than 90 degrees, or those who might have a subclinical neuropathy already. So the thinking now is to have a very, very low threshold for dealing with the nerve prophylactically. Many of us will now do a routine in situ decompression at the same time. If the patient has no neuropathy or a really stiff elbow, a formal anterior transposition is probably the safer bet. You have to protect that nerve.
Okay, let's move into the really tough territory, the bad bearing joint. Mid-arc pain, advanced cartilage destruction, but in a young, active patient where a total elbow replacement feels like a last resort. This brings us to biological resurfacing. Let's really dig into interposition arthroplasty, or IA. What is it, and how do you counsel a patient about the pretty significant risks, especially instability? Interposition arthroplasty is the classic joint salvage procedure. It's for when the cartilage is gone, but the fundamental bony shape of the joint is still there. What you do is resect the remaining cartilage, recontour the bone, and then you interpose a thick layer of soft tissue. Could be an Achilles tendon allograft, fascia lata, something like that. The attraction is obvious. You preserve a huge amount of bone stock, which is paramount in a young person, and you avoid the lifelong lifting restrictions of a total elbow. And if it fails down the line, you can still convert it to a total elbow. You've kept your options open. But what are the functional results like? Can a patient really get back to high-demand activities?
The outcomes are modest. They're acceptable for a salvage procedure, but we have to be realistic. It provides reliable pain relief, but function will never be normal. We typically see their MEPS scores, the Mayo Elbow Performance Score, go from a pretty miserable pre-op score of around 40 up to about 75 post-op. Now, for some high-demand patients, that's enough. They'll trade perfect motion for the freedom to stay active without restrictions, but you have to set those expectations very clearly from the outset.
And the elephant in the room is stability. You mentioned it. A cumulative complication rate of nearly 40% is huge. And the risk of instability, which you said carries a 100% poor outcome rate. That's a terrifying number to quote to a patient.
It is. It's an incredibly high-stakes conversation. We focus heavily on that 8% risk of postoperative instability or subluxation, because if that happens, the procedure has failed. The patient has to understand that we are inherently destabilizing the joint during the surgery. We often have to release the collateral ligaments to get the exposure we need to put the graft in.
So if you're taking the stabilizers down, how on earth do you put them back together?
Meticulously. The procedure isn't just about putting the graft in. It's about robustly reconstructing the soft tissue envelope. We use techniques like a box loop reconstruction, where you use a long allograft tendon woven through bone tunnels in the humerus and ulna to recreate both the medial and lateral collateral ligaments. But even that isn't enough. That reconstruction has to be protected, and that almost always means using a hinged external fixator.
Right, so the fixator is a key part of the procedure. What exactly is its role?
It has two critical jobs. First, it protects that ligament reconstruction for the 3 to 6 weeks it takes for the graft to start healing. And second, it allows us to distract the joint by 2 to 4 millimeters. We gently pull the joint surfaces apart. That offloads the new interposition graft, gives it a chance to heal and mature without being immediately crushed. It's a fine balance, but that period of protected, distracted motion is absolutely essential for success.
Now that all assumes the basic bone structure is there. What if the damage is really isolated? Say, a bad distal humerus fracture that's healed badly, but the ulna is actually in pretty good shape. Is there a role for a hemiarthroplasty?
There is, and biomechanically, it's a very appealing idea. An EHA elbow hemiarthroplasty replaces just the humeral side, the trochlea, and capitellum. You keep the patient's own ulnar surface. The big advantage is you avoid the whole linked mechanism. You have no polyethylene on the ulnar side to wear out, which is a classic failure point in total elbows. In theory, it's a fantastic bone-preserving option.
In theory. But in practice, we hear a lot of frustration about accessing this technology.
We do. And that frustration is almost entirely down to regulatory hurdles, particularly in the U.S. These devices are often designated as Class 3, the highest risk category, and that means they need this incredibly extensive pre-market approval process. The result is that it's stifled the market. Modern anatomic systems that have been developed elsewhere, like the latitude system, which gives you different sizes to match the patient's anatomy, they're often just not available in places like the US.
So what does a surgeon do if they think a hemi is the right choice? What's the compromise?
It's a bad compromise. They're forced into an off-label use of a different product. They end up using the humeral component from a total elbow system, but that component was designed to link with a plastic socket, not to articulate with native bone. It's often not the right shape or size.
So you get a mismatch.
A huge mismatch. You get joint incongruity, abnormal loading, and that's why the results for off-label hemi for PTA are, well, they're really variable and often quite poor. You see complication rates as high as 63% in some reports. The functional scores are often no better than an interposition. It's a classic example of how regulation can unfortunately get in the way of what might be a better biomechanical solution for the patient.
Which brings us to the final option, total elbow arthroplasty. The definitive procedure for end-stage disease. So successful in the low-demand elderly RA patient, but the story just completely flips for the young active patient. Why are the results so much worse? Revision rates of up to 37% in the under 40s. That's a catastrophic number. What is the fundamental biomechanical flaw in our current designs that leads to this?
The first thing you have to tell that young patient is that a TEA is a salvage procedure. It is not a return to a normal elbow. The high failure rate comes down to two things: the patient's inability to stick to the restrictions, and the inherent mechanical weaknesses of the semi-constrained link designs we use. We tell them you cannot lift more than 10 pounds in a single lift and no more than 2 to 5 pounds repetitively for life. Now, you tell that to a manual laborer or a young active person, they are the least likely group to adhere to those rules. So non-compliance is a huge driver of failure.
But the implant itself is vulnerable. Let's really break down that non-anatomic force transmission. It sounds like the surgery itself creates the problem, and the implant design then exploits that weakness.
That's a perfect way to put it. There are three interconnected problems, and they all stem from the standard surgical technique. The first problem is that we systematically destabilize the elbow. To get the implant in, the standard surgical teaching is to release or even sacrifice the medial and lateral collateral ligaments. We also often resect the radial head.
Which is so counterintuitive. In almost any other joint replacement, preserving the ligaments is the #1 priority.
It is, but in the elbow, to get the exposure, we take them down. And in doing so, we remove the joint's primary and secondary soft tissue stabilizers. The joint is now entirely dependent on the implant for stability, which leads to the second problem, the sloppy hinge. These semi-constrained implants have a few degrees of built-in laxity, a bit of varus valgus wobble. That's intentional to stop it being a rigid hinge, which we know fails very quickly. But without the ligaments to guide motion and absorb shock, all of those forces go directly through the metal hinge and the polyethylene bushing. The load isn't dissipated, it's concentrated right on the implant, and crucially, on its fixation to the bone.
Okay, so that leads to the third problem, I assume, which is how those forces are transferred to the bone itself.
Yes. This is stress shielding. Because the forces are no longer going through the normal joint surfaces or ligaments, they are transmitted down the metal stems of the implant and into the bone shafts, deep inside the humerus and ulna. And this means the bone right next to the joint, the humeral condyles, the proximal ulna, is now shielded from stress. And according to Wolff's law, if you unload bone, it resorbs. So over time, we see this predictable, irreversible melting away of the bone stock right around the implant.
And if that bone disappears, the leverage on the implant must increase. That's the increased moment arm.
Exactly. The moment arm is the distance from the center of the hinge to the point where the load is actually transferred to the bone. As the bone near the hinge resorbs, that distance gets bigger. A bigger moment arm means exponentially higher cantilever forces on the stems and the cement. It dramatically increases the risk of aseptic loosening and, the worst-case scenario, a paraprosthetic fracture. And it's a vicious cycle. When you have to revise it, you need an even longer stem to get fixation in good bone, which makes the moment arm even bigger and the stress is even higher.
So with all these vulnerabilities, what are the most common ways these implants actually fail in the clinic? What are we looking for in follow-up?
Aseptic loosening is still #1. You'll see clinical loosening in about 5% of patients, but if you look at x-rays, you can see radiolucent lines around the stems in a much higher percentage over time. The second is polyethylene wear. All those forces going through the sloppy hinge just chew up the plastic bushing. This leads to increasing instability. We have radiographic markers for this. If you see more than 10 degrees of angulation at the hinge on a stress view, that's considered unacceptable wear, and you need to revise it before it breaks completely. And finally, you get catastrophic mechanical failure. The cement holds, but something else gives. The locking pin can break, so the hinge dissociates. Or, in the worst cases, the metal stem itself can actually have a fatigue fracture.
Okay, so having laid out just how fragile these TEA systems are in this demographic, let's bring it all together. Let's build a practical treatment algorithm for that young, active patient who walks into your clinic. How do we structure that conversation?
The entire algorithm has to be built around one principle: preserve bone stock, with TEA as the absolute final, last-ditch option. So step one, you have to be absolutely rigorous with conservative treatment, activity modification, analgesia, steroid injections. You give it a proper go. Then you reach the triage point, which is all about the symptoms and the x-rays. So scenario one, terminal pain only. The cartilage looks good. This is your impingement case.
Right.
You proceed with an osteocapsular arthroplasty, either open or arthroscopic. Decompress the joint, release the capsule, and critically have a very low threshold for decompressing the ulnar nerve at the same time.
Okay, scenario two.
Scenario two, mid-arc pain, the bad bearing. This is where you enter the world of salvage. If the bony architecture is preserved, you can consider an interposition arthroplasty. This is for the patient who cannot or will not accept the restrictions of a TEA. You have to be honest about the modest functional outcomes and the high complication rate. And success is entirely dependent on restoring stability with ligament reconstruction and an external fixator.
And if it's just the humerus that's damaged?
That's your niche for hemiarthroplasty. If you can get an anatomic system, it's a viable option. If you're forced to use an off-label TEA component, you have to be extremely cautious and counsel the patient about the very high risk of a poor outcome. And that leaves scenario three: severe bone loss, a failed previous salvage surgery, or a patient who is finally willing to accept the limitations. That is when, and only when, you proceed to total elbow arthroplasty.
And when you get to that point, does the choice of implant-linked versus unlinked make any difference to those biomechanical problems you outlined?
In theory, yes. In practice, it's very difficult. An unlinked system, which relies on the patient's own ligaments for stability, would be preferable. It would share the load more physiologically and reduce the stress on the implant fixation. But the reality is, the typical PTA patient who needs a TEA has terrible soft tissues, deformity, bone loss. You often can't get them stable enough for an unlinked implant to work, so you're forced back to using a semi-constrained linked implant, and you're immediately back in that world of high revision risk, stress shielding, and moment arm failure. Hashtag tag outro.
We've covered a huge amount of ground here, exploring the very real challenges of managing advanced elbow arthritis in these younger, more demanding patients. It's so clear that every decision, from a simple debridement to a complex resurfacing, has to be made with one eye on preserving future options and bone stock.
I think the final takeaway is this: the decision to offer any kind of arthroplasty to a young, active patient has to be governed by a deep understanding of the biomechanical fragility of our current implants, and an equal understanding that success in joint preservation comes down to meticulous restoration of stability. We're offering pain relief, absolutely, but we're also making a very explicit trade-off in long-term durability.
If you found this deep dive valuable to your practice, please do take a moment to rate and share the show with your colleagues. A huge thank you for synthesizing all this complex evidence and walking us through these critical decision points today. It's been incredibly insightful.
It's been a pleasure. Thank you for having me.
My pleasure. And a final provocative thought for everyone listening. If mechanical failure in total elbow arthroplasty is fundamentally rooted in our surgical technique, that decision to sacrifice the collateral ligaments to get the implant in, then how can future implant designs ever truly succeed without first finding a way to integrate those stabilizers back into the procedure? And what will it take to change the regulatory landscape to let us use the more bone-preserving anatomic technology that we need? Something to think about until the next deep dive.